Move on to Dr. Connie Smith-Hicks, who is an assistant professor of neurology at Johns Hopkins. She is a child neurologist who specializes in the care of patients with genetic causes of ID, autism, and epilepsy. And at Johns Hopkins runs a Center of Excellence for SYNGAP1 and the Rett Syndrome program, at Kennedy Krieger Institute. She also directs the translational research program. I'm excited to hear what she's going to talk to us about today. Thank you. Looks good.
Okay, great. Thank you. Thanks for that introduction and for inviting me to share some of our work. As you heard, I'm going to be talking about SYNGAP from the clinic, which is a little different take from the talks you've heard so far. My talk is going to be divided again across two broad questions. First, I'm going to be talking about the clinical features of SYNGAP1, and then I'll move on to talking about some of the work we've been doing to better characterize or deep phenotype our patients with SYNGAP1. You've also heard a lot of conversations about the Syngap protein and its role in synaptic plasticity, activity-induced LTP. The model that I'm showing here is out of Rick Hugener's group, and Mary Kennedy shared with us that there are some differences between her model and his, primarily as it relates to the Syngap protein and its at the basal state and its interaction with RAS. However, in the wild type or normal neuron, according to Rick's model, Syngap is thought to negatively regulate RAS, and in so doing, reduces or does not increase the number of AMPA receptors of the surface. In the situation where there is increased synaptic activity, SYNGAP1 releases its negative pressure, negative inhibition on RAS, and through a number of steps results in increase in AMPA receptors to the membrane, increase in actin polymerization, enlargement of the dendritic spine, and processes that play a role in activity-induced LTP. When there is reduction in Syngap protein, as in the case of Syngap haploinsufficiency, the basal state of the dendritic spine is very similar to that seen in activity-induced LTP. And it's that enhanced basal state that occludes the possibility of further LTP upon synaptic activity. It is this inability of the neurons to appropriately respond to synaptic activity that we think is contributing to the clinical phenotypes that we see in our patients with SYNGAP1. And the seminal paper that came out in 2009 by Hamden's group reported on 3 patients who were not related. They had de novo mutations in the SYNGAP1 protein, and they were determined to have non-syndromic intellectual disability. Since then, over 100 pathogenic variants have been reported in the SYNGAP1 gene, and SYNGAP1 is thought to account for about 1% of cases of epileptic encephalopathy and ID. The heterozygous pathogenic variants in SYNGAP1 are thought to account for about 89% of all cases, where the deletion at the chromosomal locus of 6p21.3 accounts for about 11% of the patients. All patients with SYNGAP1 are reported to have some degree of global developmental delay. Speech is primarily affected. Some are verbal, others are minimally verbal, and there are those who are nonverbal. Behavioral challenges are a common feature, as is sensory processing differences. Intellectual disability, epilepsy, and abnormal EEG is seen in about 88 to 96% of patients, depending on the study and the cohort of patients, and autism is seen in about 50% of patients. The remaining clinical features, sleep, acquired microcephaly, strabismus, constipation, scoliosis, and gait, the prevalence of those clinical features in SYNGAP1 is not yet clear. Now, Jimmy Holder's group published a paper in last year that indicates that there is a developmental delay occurring across all developmental milestones. Notably, the many patients exhibited their first word at about 35 months thereabouts. And those who started to walk independently, on average, they walked at about 20 months. And then with regard to fine motor skills, patients acquired that around about 50 months or so. Ingrid Scheffer's work is perhaps the largest cohort of patients that have been reported with SYNGAP encephalopathy. And in her work, she indicates that the more common seizure types include myoclonic atonic seizures and epilepsy with eyelid myoclonia. They've also shown that about 98% of patients with SYNGAP1, at least in their cohort of 57 patients, demonstrate epilepsy. The median age of onset is about 2 years old, and the range is 4 months to 7 years old. The vast majority of patients have generalized epilepsy, and over 50% of them have multiple seizure types. Although there is still a lot of work to be done with regard to phenotype-genotype correlations, Cyril Mignot's group suggests that patients with pathogenic variants in exons 4 and 5 are more likely to have pharmacosensitive epilepsies. The take-home from this slide really is that SYNGAP1 is a multi-systems disorder. We see large involvement in brain-based features. There's some GI involvement and some bone or skeletal features that have also been identified. Now, problem behaviors are very commonplace in SYNGAP. We often characterize them in two major groups. There are the dangerous behaviors that encompass self-interest behaviors, aggressive behaviors, disruptive behaviors, and elopement, and interfering behaviors such as restricted and repetitive behaviors. We also note that patients that are likely to have significant behavioral problems are those that are dually diagnosed, for example, those with autism and ID. Now, to further define disruptive behaviors, we have the self-interest behaviors that are defined based on injury to self as compared to aggressive behaviors that are defined as injury to others, and disruptive behaviors, breakage of objects in the environment. Elopement is a major challenge for many parents when it does exist, as kids tend to leave their supervised care without permission. Now, the restricted and repetitive behaviors are defined based on the degree to which they interfere with adaptive behaviors. They can manifest as obsessive behaviors or fixation on topics, or repetitive non-functional behaviors. So far, there have been 5 manuscripts that have reported on behavioral phenotyping in patients with SYNGAP. You can see that they've all acknowledged that there are some degree of aggressive behaviors in SYNGAP1. However, there is no report to date of patients with eloping behaviors. Work done in our group by Griffin Roker, BCBA, in our cohort of 8 patients shows that patients with disruptive behavior and repetitive restrictive behavior, or rather these behaviors are present in 100% of our patients. In about 62% of patients, we have identified elopement, and aggression and self-interest behaviors are reported in a similar number of patients. Now, cognitive difficulties, cognitive disabilities is commonplace in SYNGAP1. Many of the earlier work have identified or indicates that about 100% of patients with SYNGAP1 have cognitive difficulties. The tools that are routinely used in clinical practice tend not to measure IQ very well in individuals with IQ below 55. And this is in part results in the inability to parse the clinical strengths and weaknesses of our patient population. It also results in the vast majority or many of our patients sort of clustering at the floor of the measure. So one of the things that we have been working on is trying to identify measures that can be used in patients who are nonverbal or who have disruptive behaviors. We have also tried to identify measures that can be used across the lifespan and that can be completed in a short period of time. To that end, we use the KBIT2 to evaluate IQ measures, the PPVT5 to evaluate receptive language, and we use several measures from the NIH toolbox to evaluate other cognitive constructs such as cognitive flexibility, inhibition, attention, working memory, processing speed, and episodic memory. You can see here that we had pretty decent feasibility scores with the KBIT2 and the PPVT5, but the feasibility sort of decreased over time with the NIH toolbox measures that we used. We think that feasibility is not only influenced by the cognitive abilities of our patients, but certainly by their epilepsy, since about 4 of our patients had seizures during the testing, with 3 of them having a significant persistent epilepsy or seizures, and several had behavioral challenges. When we look at performance as reported here in standard scores, we can see that there are some patients who functioned in the low average to average range, and we can appreciate that there is relative strengths in the dimensional card sorting task that looks at cognitive flexibility and the flanker tasks that looks at inhibition and attention. We also noted that several of them clung to the floor of the measure for their KBIT tools. We were really encouraged by the fact that our PPVT measure was able to give some granularity in the receptive language functioning, and we were able to capture an individual with a standard score of 20. So this is pretty encouraging for us. Now, sleep in SYNGAP, we have done some work in collaboration with Jimmy Holder using the Childhood Sleep History Questionnaire. And what we're reporting here is that patients with SYNGAP had pretty elevated total scores when compared to typical developed patients. The increase in scores results from increased bedtime resistance, some degree of sleep anxiety, sleep awakening, sleep disruption, and parasomnias. Disordered breathing, such as obstructive sleep apnea, was not commonly reported. And we note that sleep onset delay was also not commonly reported. And we think this might be due to the fact that many patients use medications that target sleep onset delay. Most commonly used medication would be melatonin. Now, several patients in our study indicated that speech, motor delays, learning and behavioral challenges were pretty commonplace and certainly had a greater impact on quality of life. You'll note that 5 patients are reported here as being formally diagnosed or formally given a behavioral diagnosis. However, 16 families reported that behavior significantly impacted their quality of life. The most problematic behavioral symptoms were attention, irritability, perseverative behaviors, and this was followed by sleep and seizures. Now, medications that are commonly used in our cohorts, certainly the anticonvulsants. This is followed by medications that target sleep, and then medication that targets behavior or mood. The most common anticonvulsants in our group was the CBD Epidiolex agents, lamotrigine, and clobazam. Few of our patients were on valproic acid. Agents that are commonly used to target the behavioral phenotype included the Adderall, sertraline, and alpha-adrenergic guanfacine, and risperidone, with melatonin being the most commonly used to target seizures, followed by clonidine and trazodone. When we looked at the percentage of patients who were on anticonvulsants and we parsed it according to the number of anticonvulsants, it was interesting to note that the vast majority of our patients were only on one anticonvulsant, with fewer patients on 2 anticonvulsants or 3 or more. It was also interesting to note that although some patients had clinical seizures, they were not taking an anticonvulsant. It's not clear at this time the reason for this, as this was determined upon assessment or analysis of our data set. Some of the other things that we have been doing at the Institute is we have been looking at EEGs as a marker of brain response to sensory input. We've been looking at gaits. We've been using the actigraphy to evaluate both sleep and behavior, and looking at some blood-based measures to not only deeper phenotype our patients, but hopefully identify biomarkers that can prepare us for clinical trials, as I'm hopeful that some will come on the way shortly. So I'd like to close by acknowledging the Syngap Family Foundations, all the parents of children with SYNGAP1 who have participated in our studies and supported our work, certainly our funding institutions, my research team, and our collaborators. Thank you.
Great, thank you so much. Do we have questions? Don't see any yet in the chat or the Q&A. Obviously, the behavioral component is a really important one, I think, for families. I think it would be important to think about how we look at this in models that are developed, right? And therapies, and do they treat not just the seizures and development, but the behavioral components as well?
Absolutely. If I may just speak to that a little, historically in clinical trials, there have been parent-reported questionnaires that are routinely used. One of the things I didn't really talk about is some work done by Griffin Roker of BCBA, who is looking at functional assessment. So evaluating patient behavior based on structured videos. And so we're hoping to pursue that some more and perhaps develop some informatics approach to quantifying those behaviors.
Great.
I have a question, and it seems I'm not allowed to type questions since I'm stuck in as a panelist. So I'm going to use my privileged position here. Connie, for those people who didn't have anticonvulsants, is it possible that they had either a metabolic or dietary therapy, and or, dare I say it, not Epidiolex, but over-the-counter CBD as a treatment? I mean, how do you capture that in your data?
So yes, I captured CBD in our data set. And so for the patients who were not on anticonvulsants, that does not include those who are on CBD. So I counted CBD as, since it's being used to treat seizures, I counted in the group of patients on anticonvulsants. And with regard to dietary, as it relates to probably keto diet or Atkins or anything like that, none of the patients in our cohort was on any dietary measures to target seizures.
Great. And a couple of quick questions here. Will your studies of patients continue over time to see progression of the disease? For example, my son had terrible sleep early on, but as a 19-year-old sleeps fairly well.
Absolutely. So what we have done is really the work that I've shown you is a pilot data set, really to have better insight into the measures that would be appropriate for this population. And the goal is then to use the information that we have ascertained from that pilot data set to look at outcomes and natural history over time. So that is the step in which we're moving. And so we'll be looking at larger cohorts of patients, not only evaluating their sleep and behavior, but also their cognitive profile. We'll also be expanding our data set to look at not only the younger kids, but also the older kids, 18 and over. Our data set only included kids 17 and younger.
I think that's great because so many families diagnosed early want to know what life looks like later, right, as adults. That's great.
Absolutely.
One last question from Lindsay Meisen. I'm interested to know how well, in your experience, patients tolerate investigations like EEG.
So we here at the Kennedy Krieger Institute, we use someone who is sort of trained in behavioral therapy to help facilitate the patient's tolerance of the EEGs. So it's very commonplace that we are able to accomplish EEGs, both overnight EEGs and 4-hour EEGs in the vast majority of our patients. For patients who are not able to, we are able to perform behavioral desensitization to help them adapt to the EEGs. And for those who are not able to tolerate that, we are able to do sedated EEGs using agents that do not interfere with the epileptiform activities.
And then one more question popped up here. What were the ABA therapies' impact on behavioral modifications?
So in our studies, we have not looked at behavioral modifications, but really just behavioral characterization. So trying to identify the features of the behavior, the antecedents of the behavior. So that was really the focus of our work. I know it's not so much behavioral modification. But clinically speaking, there are several patients that I follow who have received behavioral therapy in the form of ABA. Some of those patients have been given a formal diagnosis of autism. And, behavioral therapy in the form of ABA is as good as the person providing it. But certainly many of our kiddos do gain some skills, and there's a reduction in some of the behavioral challenges.
Great. Thank you. That was a really nice, comprehensive overview of the phenotypes. I think, and those are some good questions, so thanks from the audience. We'll move on to our next.